This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Justin Abbatemarco from the Neurology podcast, and today we're kicking off a 4-part series on all things related to autoimmune encephalitis. We're going to sit down and talk with experts across the world to help distill the most salient points in the diagnosis and management of this disease. And we really want to focus on practical management strategies because these cases can be difficult to manage in the real world. And I think there's growing awareness among other specialties such as oncology, rheumatology, psychiatry, that have placed neurologists at the forefront of these conversations. Our series will cover the approach to testing to the long-term treatment for these disorders, while also peering into the future to see what's on the horizon. I can think of no better person to help start this conversation than Josep Dalmau. Josep is the director of the Neuroimmunology program at the University of Barcelona and a distinguished professor at the University of Pennsylvania. Josep and his research team helped usher in this new era with the discovery of NMDA receptor encephalitis in 2007. So I'm excited to welcome him back to the podcast. Hello and welcome.
Thank you very much, and thank you for inviting me to participate in this group of talks.
And maybe we could start off our conversation with any updates around NMDA receptor encephalitis.
I think that there are several things going on with this disease. Many people know now the acute phase of the disease, but the long term and particularly the post-acute stage of the disease is not so well known. There are studies now approaching this topic, and we are very interested in the post-acute stage of NMDA receptor encephalitis. Just for example, everybody probably knows what to do in the acute stage. The patient probably is going to be admitted to the hospital, sometimes to the ICU, is going to be receiving immune therapy, is going to be checked for the presence of a tumor, and is going to be supported in terms of any complications that patient may develop, but at some point will improve, it will substantially improve of many neurological symptoms, and will be discharged from the hospital at home or many times to a rehab center to have cognitive rehabilitation, for example, cognitive training. But nobody knows exactly how to treat the patients when they leave the hospital. And we are very interested in this and recently published a very comprehensive study of these patients in the post-acute stage, in which we also included a group of patients or healthy participants and a group of patients with schizophrenia, and all of them underwent multiple different tests, neurological, psychiatric, neuropsychological, and a sleep test, and the findings were compared. And we learned very interesting things of these patients, like, for example, that the cognitive and psychiatric symptoms at the post-acute stage are not so different from the ones identified in the schizophrenia patients. But the difference was that the patients with NMDA receptor encephalitis showed progressive improvement during the year follow-up that were included in the study compared with the schizophrenia patients. But there are many aspects in this study that I think help us to understand better the disease, and perhaps also to understand better how to design clinical trials.
I wanted to jump back to that first point you were making, that become better at managing or identifying these patients in the acute setting, right? But we have a gap in our care for the chronic management after the patients leave the hospital, the rehabilitation center with NMDA encephalitis. Do you have other thoughts? How do you approach those cases? What kind of resources do you highlight for the patients to help with their recovery?
We have a continuation of the study that I just mentioned. This study was published in Lancet Neurology last year. And now we are doing a similar study, but trying to help the patients at home. That study showed basically is that most of the patients, they are no longer having, at least in this disease, of course, they are no longer having seizures or abnormal movements. What we would say, clear neurological symptoms, but they are left, of course, cognitive alterations is a neurological problem, but they are left basically with this, with cognitive alterations and psychiatric problems. So I think that the patients need a multidisciplinary approach and a very close follow-up, and also rehabilitation in terms of cognitive training. And we are trying to do this at home remotely, and even we are doing this remotely in terms of sleep studies and EEG registry remotely. So this is what we are doing. The idea, based on findings of the first study, is that if we help these patients with intense cognitive rehab during the first 6-7 months, after being discharged from the hospital, perhaps we are going to help them to improve or expedite the improvement. What the study doesn't address, and I think is going to need other studies, is for how long these patients should be on immune therapy. Many of these patients are no longer on immune therapy when we do this to them.
Definitely some unanswered questions, but things that we can do in the meantime, right? Even just getting with cognitive, physical rehabilitation services, focusing on holistic care like sleep. It sounds like these things are really important in the patient's recovery.
Yes, I think that is important. And of course, we manage this in a personal way. There is a study that we have completed, is not published yet, in that the impact of following the patients very closely in terms of trying to understand better the disease comes with very important surprises. Is that we have done a similar study with patients with anti-LGA1 encephalitis. And in here, the surprises were even bigger, in terms that a substantial number of patients that are thought that they are cured or substantially improved, they are much less better of what we think. It happens that in this disease, when you do systematic, very close follow-up with, for example, video polysomnography or EEG, what we identified, for example, is that in 50% of the patients, they still have REM sleep behavior disorder, and still have, in about 20%, still have focal onset seizures that patients did not describe, the families did not describe, and the physicians were unaware of them. And this is uncovered by this continuous registry. And of course, this has a lot of implications in terms of other symptoms. For example, the patients that have focal onset seizures or still have facial-brachial dystonic seizures several months after the treatment, and that you can see them particularly well during sleep. This interferes with sleep, and there is a sleep fragmentation. And of course, this also probably affects cognition. So there is a first step in all these diseases, which we think that we know, and perhaps we don't know so well. And the first step is to try to learn from them and to improve of knowledge.
We think that we have a good grasp on this, but the more monitoring and investigations we do, I think we're seeing some gaps, especially in that long-term management. And so a ways to go for us in this field. Maybe we could shift gears a little bit and talk about paraneoplastic neurological disorders. We've had some important updates around that. There were diagnostic criteria published in N2 in May 2021. And we've seen some work around why certain patients develop these disorders, maybe related to some genetic alterations that trigger the immune breakdown. How has that changed your practice so far?
Well, in terms of the genetic alterations identified in some tumors, the main work was done by the group of Honorat, and the main work was done on patients with that have anti-YO paraneoplastic cerebellar degeneration, and studying mainly ovarian cancers of these patients. There are previous studies done by here and by my colleague here in Barcelona, Cesc Graus, in patients with breast cancer, showing that in the case of ovarian cancer, showing that there is overexpression of the CDR2 and CDR2L in the tumors of the patients, and mutations also of this protein. which is the main antigen of the disease. And this was done in ovarian cancer, but not in breast cancer. It was not found in breast cancer, but in ovarian cancer. In breast cancer, it was found that the paraneoplastic breast cancers have overexpression of the HER2 gene. But again, these are interesting findings, but have not changed practice, at least until now. And in terms of the criteria for the paraneoplastic syndromes, yes, this was published not long ago in N2 on this update on the criteria. And the main reason is that the previous criteria for paraneoplastic syndromes were published in 2004, which is just before the era of the autoimmune encephalitis. And so I think these criteria are interesting because you learn from reading them and some general concepts. And for me, one part that is interesting, for example, is that some terminology has been changed in order to reflect that not all the diseases associated with antibodies against intracellular neuronal proteins are paraneoplastic. For example, the GAD65 or the AK5 syndromes associated with these antibodies, these are many times not paraneoplastic. And the other way around, that what is called autoimmune encephalitis, like separating them from the paraneoplastic syndromes, well, this separation is incorrect. This is not so clear. For example, there are autoimmune encephalitis, like, for example, associated with AMPA receptor antibodies or with GABA B, or even the NMDA receptor encephalitis, right? In that some patients have tumors. Benign in case of NMDA receptor encephalitis, usually a benign teratoma, sometimes malignant, but usually benign. But for the other ones, you find that about 50-60% of patients, they can have lung cancer or can have other types of cancer in cases of the GABA B or the AMPA receptor encephalitis. So in some way, these are paraneoplastic syndromes. It happens that these ones respond much better to treatment than the ones in that the antibodies are against intracellular proteins.
I think highlighting that idea of terminology matters, right? It ensures that we have the right diagnosis, that they're getting the comprehensive care that they need, and then we're communicating it to other specialties. I think it's really important. You recently published an article in Lancet Neurology in June 2023 discussing antibody-negative autoimmune encephalitis, where you expanded on your work in the 2016 position paper, talking about the clinical approach to the diagnosis of autoimmune encephalitis. What prompted this latest publication?
Well, there are two reasons that prompt us to write this review that is categorized as personal view, but actually includes also a very comprehensive review on papers published on seronegative autoimmune encephalitis. But the very first reason is to emphasize the importance of the diagnostic algorithm, not criteria, but algorithm that was published in 2016 in Lancet Neurology. Although many people refer to this paper by the Gauss criteria, etc., the main point is not this. There are criteria that are embedded in an algorithm to help to make the clinical diagnosis of autoimmune encephalitis. The paper sometimes is, I don't know if it's misunderstood or the people jumped to the criteria and to the few tables that the paper has, but it has to be read from the beginning to the end. The main goals of this initial paper of 2016, the main goals of the diagnostic algorithm were to facilitate the clinical recognition of autoimmune encephalitis in order to support initiation of immune therapy without waiting for the antibody results. So that's very important, that you have to keep this goal in mind to understand the whole process or the whole entire algorithm. So the idea is clinically recognize these patients, for example, in a moment in that you are in a place or in a country in that the antibodies, you don't get the results in 2 days, but it can take several weeks. So what to do? So this is the main idea. And it was particularly focused on acute autoimmune encephalitis because these are the most difficult situations that one encounters. The chronic encephalitis or patients that come with opsoclonus, myoclonus, which is also a form of encephalitis, that's not the goal here, right? The goal was what I mentioned. And I think that by jumping sometimes too fast through the tables of this paper or through the few criteria embedded, people also miss some critical aspects of it. For example, the three minimal requirements to suspect that a disorder could be autoimmune encephalitis. This was called possible criteria of autoimmune encephalitis, but are not disease criteria per se. These are the minimal requirements. These are the checkpoint that if you pass the checkpoint, these requirements, then is when the work starts. Then is when you have to go through the algorithm, and that will help definitely to make the diagnosis of many patients. There was recently a paper about misdiagnosis of autoimmune encephalitis, and it was very clear that if you follow this criteria, most of the misdiagnoses were gone. And then we also wanted to emphasize very much that there are disorders to exclude, that there is a very important point here, which is pay attention to the disorders to exclude in this initial checkpoint, right? And what we have done in the most recent paper is clarify these and particularly emphasize the disorders that should be excluded, which many of them are easy to exclude, but one should keep them in mind, right? And then the second reason of the most recent paper was to address the seronegative autoimmune encephalitis. There is a flurry of papers of seronegative autoimmune encephalitis, which, in our opinion, and with all respect for all the authors, are inaccurate. For example, one cannot talk of seronegative autoimmune encephalitis if only serum is examined. That's a major flaw. Many times because the antibodies are only identified in CSF. There are nowadays probably more than 30 antibodies reported, definitely more when you count cell surface and intracellular. So one cannot talk of seronegative if only 6 antibodies that are in a commercial kit are studied. So, I mean, this is incorrect. And the other thing that we found in some papers is that the patients included, they don't even fulfill the criteria or the minimal criteria of autoimmune encephalitis. So we wanted in this recent paper, we wanted to focus things because if not, the number of papers published on seronegative autoimmune encephalitis will multiply and will cause important misconceptions and errors. And this is more and more seen in terms of many times just because a patient has an inflammatory disorder that is not infectious and improves with steroids is not necessarily autoimmune encephalitis. So this is what we wanted to address in this paper.
And I just wanted to highlight that Owen Flanagan actually was on the podcast on December 22nd in 2022, discussing that paper of autoimmune encephalitis misdiagnosis in adults, discussing those key points to look for CNS inflammation and making this diagnosis. So I think those are helpful points, and folks can listen back to that episode to learn more. Maybe we could move on because it's a really exciting time in this field. We have several ongoing international clinical trials within the field. What could you tell us about those trials, and maybe also where should we be focusing our research efforts moving forward?
I think that's very important, the clinical studies about mechanisms and potential treatments of these diseases. And there is some work, we publish some work, there are other colleagues that they are working also in some treatments beyond immune therapy for the post-acute stage, for example, an MDR receptor encephalitis. I think that one that I know more, of course, is the one that we are working, and we publish preclinical data on animal models on these, which are the allosteric modulators, the positive allosteric modulators of the NMDA receptors. These are very interesting group of approaches of treatment that probably can help the patients in the post-acute stage of the disease. Then I think that an important line of studies is biomarkers of autoimmunity, neuronal damage, and inflammation. And I think that we should aim to identify biomarkers on these three categories. Some biomarkers for some diseases like neurofilament or, for example, GFAP are important. They may work in some particular diseases, particularly the white matter, but I don't see clear that a biomarker, for example, neurofilament light chain, that can be very helpful for one disease like MS, it will be so helpful in another disease. So, I mean, each disease probably will need to have research to identify biomarkers. But in thinking a little bit in a more futuristic way, I think there are probably genetic, we can use the blood test even, not necessarily CSF also, but even with blood tests with very sensitive markers that point towards of changes, more than alterations, changes in genes that control autoimmunity, neuronal damage, and inflammation. I want to put an example that is very simple and just was published basically days ago in Brain of the studies that have been done by my colleague Thais Armangué here, examining the post-acute neurological complications of herpes simplex encephalitis and the post-herpes autoimmune encephalitis. No? And this study in some way identify actually prognostic factors or factors that suggest that the patient is going to develop autoimmune encephalitis. And one of them is basically based on what's called interferon signature. There are several markers that are identified there. Essentially, there are three independent risk factors for developing autoimmune encephalitis, post-herpes simplex encephalitis. One is the presence of neuronal antibodies 3 weeks after herpes simplex encephalitis. The other is the absence of a specific haplotype, which is HLA-A02. And the other is the one to make the point here, is the transient or moderate increase of the interferon signature on day 22. So what is the interferon signature? Interferon signature is basically a panel of genes. In this case, we examine 6 or 28, a panel of genes that change due to the presence of interferon, due to the infection with the virus. So depending of the interferon signature, you can make some sort of predictions if the patient is going to develop autoimmune encephalitis or not. But the point that I'm trying to make is the interferon signature, these, for example, 6 genes or 28 genes, the two panels are equally effective. You can test them with very simple blood test. So what I envision is that similar types of tests, like for example with nanostring, etc., can be applied in the future to assess many different types of genes involved in inflammation, autoimmunity, etc. So these are futuristic studies, some of them not so far from now. And then, of course, the clinical trials, which are essential.
Untangling that interplay of genetics and neuroinflammatory diseases is really interesting. And I agree, it's really going to accelerate over these next couple of years and hopefully will really help patients. I think this is a nice example where we can maybe identify these high-risk patients in the future. Josep, I just want to thank you for this past, present, future take on autoimmune encephalitis. It's a rapidly moving target, but this type of conversation helps us stay up to date. For our audience members, this series will continue with a conversation with Soroush Irani and John Soltz with a focus on antibody testing. So please stay tuned.
Well, thank you very much, Justin. Thank you.
This is Stacey Clardy, your podcast editor. Thank you for listening and for letting us join you on your commute, while you're exercising, or even while you're brushing your teeth. This has been another episode of the Neurology Podcast, your best source of practical, relevant, and timely information for neurologists, clinicians, and patients.